Well, welcome everyone to this webinar on managing antimicrobial resistance in Asia, identification and implementation of breakthrough solutions. My name is John Lim. I'm the Executive Director of the Center of Regulatory Excellence at the Duke-NUS Medical School in Singapore, and also the Core Lead Policy at the SingHealth Duke-NUS Global Health Institute, or the SDGHI. It's 3:30 p.m. in Singapore, and I'm glad to welcome all of you, but I know there are people from Singapore, from the Asia Pacific, and at least in terms of registration, we have people from around the world. So if it's a different time zone for you, nonetheless, welcome and thank you for joining us. This particular webinar is one of a series that we run from our Center on Contemporary Topics, and most of them, as you might have expected in the last 1.5 years, are focused on COVID-19 and the effect of the pandemic. But today, we're looking at the specific issue of antimicrobial resistance in Asia. And in terms, of course, of the pandemic, there have been major issues and concerns, which in fact have taken over from the concerns of antimicrobial resistance, or AMR for short. But nonetheless, if we look at AMR through the lens of COVID-19, it can be a challenge or an opportunity to bring stakeholders together to address the issues regarding antimicrobial resistance. And we've had concerns about AMR for a very long time, for decades, in fact. But it's only really now that as we think of a One Health approach to resolving these issues, that national action plans are coming together in response to calls by the WHO, the FAO, and the World Organization for Animal Health. But of course, there are many issues and challenges, and quite a few in the Asia-Pacific region as well, which I also think explains the interest in this particular webinar regarding research and development for novel antimicrobials. And this is clearly lagging behind where we need to be. There are various challenges regarding regulation. There are particular challenges regarding financial incentives to entire development of new novel antimicrobials. But nonetheless, as we look around the world, there are new innovative models of financing. There are regulatory innovations that we're seeing, and there continues to be deep interest across governments to address this issue, both in terms of human health and animal health. What we're trying to do in this webinar is to get a sense of the issues, and we're glad to have a number of experts and key opinion leaders with us today. And we will be hearing very shortly from Professor Su Li-Yang, who is the Vice Dean for Global Health and also the Program Leader for Infectious Diseases at the National University of Singapore Saw Swee Hock School of Public Health. And he will be giving a talk to start off the session, after which we will go into a panel discussion. And to join us on the panel, we have Mr. Fabio Lamola, who's Partner and Executive Director of Asia Pacific Life Sciences and at the Center of Excellence of LEK Consulting here in Singapore. Ms. Lin Yueno, who's Deputy Director for the Antimicrobial Resistance Coordinating Office, or the AMRCO, at Singapore's National Center for Infectious Diseases, and Mr. Barry Wyman, who's Regional Market Access Lead for Infectious Diseases, Pacific Region for Merck Sharp Dohme. And without any further ado, I would like to call on Professor Su Li-Yang to take over the microphone, as it were, and to give us a talk on the topic that you see on the screen. So Li-Yang, can I pass the time over to you now?
So before we start on this topic, I would like to put down a list of potential conflicts of interest. I received lots of research funding from the pharmaceutical industry, and I've sat on a few advisory boards as well. And this is what I'll be talking about. We'll go a little bit into antimicrobial resistance and what's going on in Asia, the COVID-19 situation, which I think we all know well enough, and then look at what the pandemic has done to AMR, for which there are still relatively few publications at this point and hard data. And then finally, how do we get back on track in terms of shifting the agenda back towards AMR or any other important disease that has been neglected because of all the focus on COVID-19. But before we do that, I'd like to take the opportunity to show you a video, so please indulge me. This is work done by some of my colleagues and briefly describes what you might see as a AMR from a perspective that many of us are often not in, which is the microbiology laboratory. And I see some of you are from Pfizer in the audience, so thank you very much for also supporting this video.
Antibiotic resistance happens when bacteria adapt to survive the drugs used to kill them. This evolutionary process is speeded up by our misuse of antibiotics in both humans and animals. Because such bacteria cause infections that are harder to treat, antibiotic resistance directly results in longer hospitalizations, higher healthcare costs, and more deaths. This is a microbiology laboratory in Singapore. In here, we try to find out what bacteria are causing infections in patients and also test these bacteria to find out which antibiotics work best against them. I bet most of you do not know what drug-resistant bacteria look like or how we test for them. So we are going to show that to you using a bacterium called Serratia marcescens, which produces an orange pigment. These are agar plates on which we have placed antibiotic strips. The strips are called E-test strips, and they contain ascending concentrations of the antibiotic, which diffuses out into the agar around it. On the left, the bacteria is sensitive to the antibiotic. The space covered in orange represents the area that the bacteria can grow in. As the concentration of the antibiotic increases, the clear space around the strip increases in size as well. This clear space represents the area that the bacteria cannot grow because of the antibiotic and is also known as the zone of inhibition. On the right, the bacteria is resistant to the antibiotic. As you can see, it grows all the way up to the strip, even at the highest concentrations of the antibiotic, which is more than 100 times higher than what we routinely administer to sick people. More and more bacteria are resistant to multiple antibiotics nowadays. Here, we have big agar plates on which we have placed multiple antibiotic discs. These discs contain a certain concentration of antibiotic, which diffuses out into the agar around it. On the left, we have a typical bacteria that is sensitive to almost all the antibiotics tested, and you can see clear zones of inhibition around all the discs except one. Again, these clear zones represent the area that the bacteria cannot grow because of the antibiotics. On the right, we have a multi-resistant bacteria. It can go through virtually all the many antibiotics tested. I hope these experiments help you understand what antibiotic resistance is about and why antibiotics can fail to work against drug-resistant bacterial infections. Antibiotics are a precious and finite resource, so please use them wisely.
Thanks very much for watching through that. My very talented colleagues at Singapore General Hospital did the time-lapse videos, and one of their trainees also did the presentation. Now that you've seen it in miniature, think about what happens when these bacteria invade the body and cause disease. I always put up this slide just to remind myself and everyone that antibiotic resistance is actually ancient. Most of the antibiotics that we have today are developed from products that are produced by other microbes or fungi that's used in the competition between the microbes. And therefore, it's natural that these bacteria have also evolved resistance to them and can readily do so again or develop new mechanisms of resistance. So in some sense, antimicrobial resistance was present before there are humans and will probably outlast all of us, right? But that's not to say that it's all doom and gloom. These two papers are often quoted. One is the O'Neill report claiming that by 2050, there will be 10 million deaths a year from antibiotic resistance if we don't change our current course. And on the right side is the World Bank report, which also came out in around 2016, showing that the impact of antimicrobial resistance by 2050 will be similar to that of the 2008-2008 crisis if nothing was done. So I think the only infectious disease of a measurable, comparable impacts would be COVID-19, which we have been experiencing over the past couple of years. And this image just shows the latest about the antibiotic pipeline. As you know, it was all pretty gloomy for a while, with rather few antibiotics or new classes of antibiotics being produced since the late 1980s. But due to incentives that's put in by various non-profits and governments, we're starting to see more antibiotics being developed. But nonetheless, it is still dwarfed by the development of drugs in other areas, in cancer, in heart disease. Even for one virus, COVID-19, there are more vaccines and antivirals that's coming out compared to antibiotics that's been in the pipeline for many years, right? So there's a long way to go to catch up. And I think many of you are in the industry and you know why this is the case in terms of the incentives and the returns for developing new antibiotics. It is much poorer than most of the other drugs for different diseases. This sparked off quite a bit of international action and momentum against antimicrobial resistance before COVID-19. And this article was produced by the Interagency Coordination Group that was formed after all the world leaders signed up to battle against AMR. And they produced a number of recommendations, which you can kind of see here. And it includes things like accelerating progress in countries on antibiotic control, innovations, investing for a sustainable response, strengthening accountability, and these are the things that they have recommended for control of AMR prior to the onsets of the pandemic. I think the problem is that antimicrobial resistance is such a nebulous thing and comprises multiple types of bacteria, antibiotics, and so it's not something easy to visualize like COVID-19, for instance, or cancer for that matter. And a group of people have tried to estimate the human global burden of disease caused by antibiotic-resistant bacteria and found that there are significant challenges, not least because there are data gaps in many countries, including particularly in Asia and many countries of the Asia Pacific. My students did up this paper recently, which is due to be published in a few months, and basically looking at the spread of different drug-resistant bacteria around the Mekong in Asia. And as you might expect, there's very little data, mostly coming from tertiary hospitals or big institutions. And a lot of data from the small hospitals or in the community is unknown. And these are data gaps that need to be addressed before we can specify what we can do about drug resistance in a way that is measurable, right? There are many drivers of antimicrobial resistance in this part of the world. That's of course inappropriate and excessive prescribing of antibiotics in both humans and animals. COVID or overstretched healthcare systems can fall and fail, and that's part of the drivers of antibiotic resistance and deaths from AMR in this and other parts of the world as well. Pre-COVID, of course, there's a lot of travel. Singapore once wanted to be a tourism hub. This is less expressed nowadays, but nonetheless, the transfer and movements of people between countries, just as it spreads, different variants of COVID-19 also helps to spread drug-resistant bugs, first to the hospitals and then outside to the community. And what have the countries of the region been trying to do about this? So every country now, I think, has a national action plan against antimicrobial resistance that kind of copies off the World Health Organization's Global Action Plan. And Singapore is no different. Another student of mine looked at all the national action plans and evaluated them from a policy perspective. And I think I only put Singapore's up here, but a lot of the action plans in this part of the world and beyond are the same, right? They're kind of full of words, but they really lack objectives that were specific, that were measurable, that were time-bound. UK's National Action Plan against antimicrobial resistance that's just been revised is a model saying they would do what by what year and what are the consequences if they don't, right? So for Singapore's National Action Plan, for example, there is no accountability, and if the objectives are unmet, nobody knows what the consequences are. This year from AMR CEO can maybe talk about this a little bit more if she wishes to subsequently. So we also interviewed many of the policymakers and the key opinion leaders of AMR in Singapore, and a whole bunch of different things came up. And you can imagine that if this occurred for Singapore, then surely in the region, in other countries that are resource poor, then things could potentially be quite a bit worse. Not always. For example, Thailand has a model system for AMR control that we are also looking to emulate. But nonetheless, it is kind of the same. There's not too much engagement with the public. And then there are all the issues with infection prevention and control and how to improve antibiotic use in the hospitals. A problem that doesn't seem to happen in Scandinavian countries or in Australia, for instance. So this is just a single slide to put together the COVID-19 situation. And you can see that although things are starting to look stable, it will be a long time before we're out of the woods, right? In Singapore, for instance, the case count has been rising on a daily basis, and there have been so far 364 deaths, the majority occurring just within the last couple of months. And in countries that have been highly vaccinated and have opened up, the situation is similar. In Norway, in Denmark, the case counts are also rising as we speak, right? So although a large proportion of people living in high-income countries have been vaccinated, the situation is far less rosy in countries that are poorer and less well-resourced. And so this entire situation is consuming a lot of attention on COVID-19 and less on other diseases, including on antimicrobial resistance. Right? So how does that impact AMR? As I mentioned before, there is very little data that has been published so far, partly because I think everyone is still trying to get through this particular phase of the pandemic. But some investigators have tried to classify this and have published a paper in the open access journal eLife to describe what they think are the changes occurred. And essentially, during the phase of the pandemic where the cases mounted and before there was a vaccine, we would have seen high antibiotic use, and this occurred initially in Singapore. Respiratory tract infections, and there are very many of them, and instinct at the time is just to prescribe antibiotics. But of course, this changed over the past few months in the pandemic, and now hardly anyone prescribes antibiotics for viral illnesses, simply because we all assume it's going to be COVID-19. But nonetheless, as a healthcare system and the hospitals are filled, this has a downstream impact on infection prevention and on a lot of different areas as well that could lead to more antibiotics being used. We certainly use a lot of biocides now. There's deep cleaning, there's intense cleaning, there's whatever in Singapore, and they all use different types of anti-infective, antiviral products, which indirectly can also lead to resistance in bacteria because a lot of the genes for resistance are linked and can be transmitted together. Right? We've certainly seen that happen in the hospitals. Now potentially it's also happening in the community. And in terms of the health system's impact, I think it's been a mix, plus and minus, as I said. The burden of antimicrobial resistant illness has probably fallen in most parts of the world, but in those where the hospitals are overwhelmed by COVID-19 and the ICUs are full, then I think we can surely expect more antibiotics to use, and the price of that would be more drug-resistant bacteria that appear in the near future, hopefully after the pandemic has more or less settled, right? But I want to focus on what I think is the main impact of the pandemic, and that's its push down AMR as a priority problem and as an area for investment, right? There have been many plans that the Antimicrobial Resistance Coordinating Office has planned in Singapore, and this has been delayed. And I hear the same in other countries in the region where my colleagues have been trying to shift the focus a bit back to AMR and try to capture some resources for AMR. So there have been scaled back campaigns for both the public and healthcare workers and COVID-19 to think about rolling out antibiotic stewardship programs, amongst other things, right? So what can we do at this point in time to deal with the problem of antimicrobial resistance? I think the first thing and the most important thing is to try to get AMR back on the agenda. Right? You go to the Ministry of Health in Singapore nowadays, and they hardly have time for anything that's not COVID-19 related. But nonetheless, we have to rebuild the collaborative frameworks in this part of the world. It's ASEAN and Asia. It's good to think about how to define the impact of burden of AMR, as we have so successfully done for COVID-19. And then finally, as Professor Lim has mentioned, COVID-19 is also an opportunity because we have made so many innovations and breakthrough for COVID-19 in terms of surveillance, in terms of public awareness and communications, and even in terms of policies. And some of these can certainly be translated across for AMR or other diseases, right? So there is an ASEAN plan for AMR that's been sidetracked a little bit for a while, but certainly this is something that can be pushed on track again to have an entire region working with other regions in the world to prevent the spread of AMR. I won't go through the details of this plan. You can see it for yourself and it's available online. But essentially, it calls for strengthening public awareness, strengthening surveillance, strengthening infection prevention and control, and of course, to strengthen research and the developments of innovation as well. Right. So how do we define the burden and impact of AMR? Here, I think we can quite clearly see the link between rates in hospitals and health outcomes. But where there's been less focus is what happens in the community, what happens in food animals, and whether these do have health and economic outcomes. And I think part of this has been the pushback from, in many ways, the agricultural industry in this part of the world, and others as well, where antibiotics are used as growth promoters or to try to mass treat herd animals to prevent disease. But nonetheless, this is something that should be investigated further and researched further as well. Right? And of course, there's all the issues about AMR in the environments and what that means for us, which I think we have to better clarify. In terms of surveillance, I think a lot has been done already. COVID-19 has shown us the importance of wastewater surveillance, which was burgeoning for AMR before that. But I think the key takeaway message here is that the surveillance is not tied to outcomes. Right? We know rates of drug-resistant bacteria in certain hospitals and countries, but we don't link this with patients dying or length of stay or hospital, increased hospital costs. And I think it's important for the next generation of surveillance to try to address that. And finally, there's education and public education and awareness as well. So we have very successfully mounted COVID-19 vaccination campaigns in the community, not just in Singapore, but in many parts of the world. And I think this is an area that we can pick up and step up again as we move on into the future. We, of course, need to think about optimizing antimicrobial utilization. In Singapore, per se, it's pretty good in the public sector hospitals because we've got antibiotic stewardship there. But this is missing from private hospitals, where it's largely a profit-driven motive. And also in primary care, it's minimal because there are lots of small GP chains and GP clinics. And it's very hard to think about how to help them improve their antibiotic use, or even to understand whether they are using antibiotics well or not. And certainly in the animal production sector, this thing is of concern as well. Don't bother to look at this slide. It's too small, the fonts. But essentially, this is the crux of what we're trying to discuss here, which is what are the other policy innovations and adoptions. And what's here is basically a way of trying to incentivize further development of antimicrobials and for the pharmaceutical industry to keep investing in antibiotics. Right? So this ranges the entire gamut from preferential access, faster review times, trying to give certificates or vouchers for future drugs that a company may develop, and so on and so forth. The key thing that we're looking at in Singapore, as well as other places, is whether there can be a subscription model for new antibiotics rather than to pay for the quantity that's being used or purchased, which is what's commonly done, right? Because we recognize that people develop new antibiotics and the instinct is not to use them, to reserve them for a rainy day, but that certainly doesn't help the pharmaceutical industry develop any deep desire to make new antibiotics. And importantly, this is a problem that's recognized by the industry, and they are the ones that have been pushing us and others in the region to do something about it as well. So I've come to the end of my talk, and hopefully you have enjoyed it, and I'm happy to take any questions if you have them. Thank you.
Thank you very much, Liang. I'm going to keep my video off for a while because the internet connection is a bit unstable, but I just wanted to thank Liang for presenting this. And although he was saying he hasn't talked about this for a long time, I think it's because every time he's interviewed in the press or in the media, it's always about COVID-19. And so I found it quite interesting to listen to Liang discuss something which goes beyond COVID-19, but is nonetheless linked. The other aspect, of course, is that in his very calm and measured way, Liang is always very frank and quite hard-hitting, and he raises very significant issues which really require addressing. What we will do now is, just before we go into the full panel discussion, I'm going to invite Mr. Fabio Lamola to tell us a bit about the white paper that LEK Consulting came up with, talking about innovation in dealing with antimicrobial resistance. And so, Fabio, could I pass the time over to you to go through your slides and tell us a bit about this white paper, which can also inform us in the panel discussion later. Fabio, over to you, please.
Perfect. Thank you, John, and thank you, Liang, for the great introduction. Actually, a lot of the things that were covered on the white paper have been elucidated by Liang. So I'll try to be brief so that we can go into the discussion. But I think you know, the lives lost is probably the main number that comes up. Whether it's 350,000, whether it's 700,000, it is a lot of people dying every year because of AMR. Half of that is in Asia Pacific. And so it is a problem for Asia Pacific as much as for other parts of the world. The other issue that is clear is that Asia Pacific tends to have slightly different strains that actually cause that death. And so there is a need for potentially research that is more targeted to the strains that are specific to Asia Pacific. Again, the loss in terms of money is difficult to estimate, but it is significant. We're talking about billions every year, from 50 to 150, according to some estimates, and up to almost $1 trillion in 2050. And so again, it is a problem that is creating issue, not only from a life perspective, but also from an economic perspective. And even if you don't consider the actual, you know, the sort of economic indirect cost, the direct cost of the healthcare system is almost 10%. Imagine what you could do with 10% saved from avoiding to have to tackle AMR resistance and deploying that amount of money into cancer, into other disease areas where we see a significant amount of expenditure and death. Can we go to the next slide, please? So we've done something that goes beyond sort of the action plans that Liang was explaining before. What we've done was actually broken down each and every single activity that has been done in antimicrobial resistance across Asia Pacific. And we've tried to estimate the level of activity, but also the level of impact, current and prospective. And what we mean by that is, number one, which areas do we think there is quite a bit going on, and what kind of impact is it having? But second, which areas there isn't enough going on, and there should be efforts to step them up. So as you can imagine, national plans, especially in Asia Pacific, typically will focus on clinical stewardship, things that the country itself can address. And so as Liang was explaining, some of them lack the specificity needed, but if you look beyond that, there is clearly an effort around clinical stewardship. There is an effort around surveillance, which will be improved because of COVID-19. There is probably less effort on a country basis on diagnostics, on drug development, and on making those drugs commercially available. And the reason for that is that that's not necessarily a single country effort that needs to be done, but it is a multi-country global effort, actually, which requires industry, requires countries, requires international bodies like the WHO, ASEAN, to come together and find solutions for something that is difficult to tackle, because if you look at the industry view, it's difficult to see the returns of developing new antibiotics or developing potentially new diagnostic tools. So if you look at what could have prospective impact, is really around the new drug development, the commercial availability of that drug, and the viability, meaning having at least a minimum amount of return around the new drugs that are being launched. Again, I don't think the industry is looking for outsized level of returns, and they do have programs around areas that are less, potentially have less returns, but there needs to be some form of incentive for people to look at AMR. One other area which has a lot of activity, but we think can be pushed even further, is diagnostic tools. We do a fair amount of work for diagnostic companies, and one of the things that always jumps out is the fact that there are ways of identifying microbes and their resistance that are much faster, but typically are too expensive, especially for Asia Pacific and the hospitals here. And so the agar plates that we actually saw in the video tend to be the main way in which a lot of antimicrobial resistance is actually seen in hospitals and diagnosed in hospitals. But as we've seen from the video, it takes 12 to 24 hours to grow those bacteria cultures. And so that is time lost when you are trying to fight a antimicrobial resistance battle against unknown pathogens for at least a certain amount of time. So if you go to the next slide, please. We tried to propose some solutions that in part take from that subscription model, for example, that Liang was describing, but it sort of expands into different areas. So, for example, the diagnostic side, a bond similar to the structure that we've seen for other issues and diseases would allow to develop specific rapid diagnostic tests, which would then improve antibiotic usage, because typically doctors want to treat as soon as possible, surveillance, and infrastructure for clinical trial networks to see whether the new antibiotics are actually working. Multilateral funding for R&D, again, industry, public sector, and NGOs, where you do focus the efforts on novel class antibiotics for the escape pathogens, which tend to be the pathogens that are most resistant. And lastly, some form of subscription, minimum revenue guarantee model for commercialization. Again, subscription can be one of those, but clearly having a path to, again, a minimum amount of return helps the industry, the NGOs, and the public sector that are thinking about funding the R&D to essentially ensure that there is a way for accessing revenues and accessing budgets for the drugs. And so again, we tried to give some practical solutions, things that have been used in the world before. So the bonds are not a new concept necessarily. The multilateral funding has happened before for other diseases, and similarly, revenue guarantees have happened for other diseases before. But hopefully, focusing a little bit more on AMR would allow us to try to solve that problem more from a practical perspective, and ensuring that the necessary R&D, both on the diagnostic side and on the antibiotic side, does happen. I think that's it for my presentation. So back to you, John.
Thank you very much, Fabio. I think that's a very useful augmentation of the themes that Liang raised in his presentation earlier. And so I think some of the key things that have come up so far would be the issues of increasing awareness of antimicrobial resistance, strengthening surveillance and moving towards a One Health national surveillance approach, strengthening antimicrobial stewardship, strengthening or reducing inappropriate antibiotic use, especially in animals, veterinary use in agriculture. And I think this key thing, which picks up from this last point that Fabio was talking about on innovative financing to ensure proper incentivization to foster R&D. We will now move to the panel discussion. And I would also invite you to type in your questions into the Q&A function at the bottom right-hand side of the screen so that we can respond to them. But we will first start with some questions that were submitted at the point of registration. So perhaps we can go to the panel mode and we can then begin our discussion. But I would just like to start by picking up a point that Liang mentioned in his presentation, which was really this in terms of the national program in Singapore. And he invited Yuan actually to make some comments from the AMRCO office on the issues which our plan in Singapore deal with. And I think Liang made the point that sometimes the objectives and the outcomes are not clearly stated. So, can I put you on the spot by inviting you to begin our panel discussion by commenting on that before we go to a broader discussion?
Thanks, John. Thanks for inviting me to this discussion. And thanks, Liang, for hitting the ball over the side. Sure, but definitely happy to share that. First of all, for those who are not familiar, perhaps just to let you know the link between AMR Coordinating Office and National Action Plan. So we were set up in 2018 by the Ministry of Health with the main mandate to actually drive the implementation of the National Action Plan and coordinate across all the sectors involved, which is health, animal, food, and environment. So I was involved in the drafting of the National Action Plan. Yes, what I think Liang alluded to was that there lacked specific targets and what would be the consequence if we did not. I think at that point when we were drafting the National Action Plan, we did have a very short deadline to get it out, first of all. And this is the first time that different agencies had gotten together to discuss AMR. So before that, we didn't really know what each other, left hand and right hand, were doing. So this was the first time we got together. And then as we discussed, I think the general approach that we would talk about strategies, and hence instead of a national action plan, it became a national, we focused on the word strategic action plan. And then we outlined the strategies that we wanted to focus on, which were namely in education. I think these you outlined just now. Surveillance to increase the knowledge base, research, improving appropriate use of antibiotics, and improving prevention and control, and doing this in the sphere of industry collaboration as well as global collaboration. So at that point, there was no plans then to put in these targets, and there was also to set targets. I think we needed enough data to make science-based targets, meaningful targets, and not random target that throw a figure. We didn't have that kind of information, but in the past few years we have been collecting more data, and I think we will be on a good path to eventually start developing some of these targets. So yes, Liang, anything else?
No, it's not the AMRCO's fault because they came after the National Strategic Action Plan was established, right? But I think we are aiming to have a more concrete plan for the next round.
Okay, so then both of you can work on this together to strengthen it. But I think the good thing is there is a plan, there's an office, and I think the pieces are in place to really move forward in this area. There is a question in the chat asking what exactly is the subscription model for antibiotics? And Barry, I wonder if I could go to you, and also could you make some comments, perhaps from the industry perspective, responding to some of the issues that Fabio raised in his presentation that came up in the white paper in terms of commercial incentivization and sustainability going forward? And perhaps you can talk a bit about the subscription model as well.
Yeah, thank you very much, Professor Lim, and thank you for the question. Just to start with on the subscription model. So basically what we're exploring is how can we remove the need to sell an antibiotic with the ability to be able to have it available in the country. So as Professor Su mentioned, at the moment, new antibiotics get reserved and people don't want to use them, they want to save them for an emergency. But when you're a company releasing a new antibiotic, if no one uses it because it's being reserved, then you can't actually recoup the cost of your investment. You can't recoup the cost of registering the product and having it available in the country. And so it becomes a commercially unviable situation. In Europe, for example, we've seen drugs like plasmacin being withdrawn from the EMA because the company couldn't see a viable way of releasing that product. So it's only available in the USA, and those products will never come to countries like Singapore and the other countries in the Asian region. And with the new antibiotics that are coming, there are some very promising agents being registered. There's a good chance that some of these won't even get released in the Asian markets because there's no commercial viability. So the aim with the subscription model is to try and have it so that, say, a country like Singapore pays a set fee to any company who brings a new antibiotic to market to reward them for the effort that's gone into doing that and the cost that's gone to doing that, and not have that linked to any sales. So it could be that there is a big need for this antibiotic in some countries, and a lot of it would be made available, and in other countries there would be a smaller need and maybe very little would be made available, but it would be not dependent on the price of the antibiotic. A government would pay a set fee to have as much access as they needed for their clinical situation to those new antibiotics.
If I can add this, think Netflix. Essentially, that's the way the model would work.
And since you're on, Fabio, you mentioned the other two aspects of AMR bonds and multilateral funding. Mm-hmm. How would you sort of compare and contrast the three? I mean, those two in relation to the subscription model.
Yeah, I think as Barry was explaining, that the subscription model is probably more appropriate for something that is already on commercial stage, where you are at the point where you want to sell it, but you don't see the case of releasing that antibiotic. So that allows you to have a sort of minimum revenue guarantee. And, of course, if you go over a lot, that sort of minimum production set, then you have to question whether the subscription was set at the right price, but that's a different issue. The other two are probably more for the step before that, which is actually setting up the R&D function, both from a diagnostic perspective, but also from a antibiotic perspective, so the R&D for the drug itself. There are slightly different ways in the sense that, for example, the AMR bond could work in a way where a central entity issues the bond and people essentially pitch in, and they have a minimum amount of guaranteed return on that bond, which is 1% to 2%, relatively small in terms of interest, but allows for funding at a relatively low cost of capital. Because if you think about the difference between the cost of capital for a company, for a public company like MSD or Pfizer, that's in the 10 to 12%. If you think about the cost of capital for a bond, that's like lending to a government, so 1%. And so essentially you see vastly different cost of capital and vastly different return profiles for those bonds. And so that's the idea behind the bond. On the multilateral funding is probably more classic, much like the WHO is funded, which is multilateral fees essentially being paid by various countries. And again, probably countries with higher revenues, not necessarily higher disease burden, would be pitching in more than countries with lower GDP.
Thanks. Liang, any further comments on this issue?
No, I think it's been summarized very well by Barry and Fabio.
John, if I could just make one final
Please,
comment. Yeah. I think it's worth just looking back at where the problems all start, and that's with the generic medicines available at very low cost. So if you look at the most powerful antibiotics, things like meropenem, they're very, very affordable for a hospital because they're generic, and so a low-cost manufacturer can come in and sell them very cheaply. And that sets the cost effectiveness for what all new antibiotics are compared with. And so that's where the disconnect starts right at the beginning. It's the price of the generic medications. I particularly like the model that Sweden has introduced, which is where they've now, for any new or novel antibiotic, they just pay them a set fee for making the product available. It's not a very large fee, but it's enough to cover the cost of registration and stocking the product. And then it's up to the company to sell at whatever price they think is appropriate in that market. So there are many ways to look at it as well. They're just two of them. So thank you. Thanks,
Barry. Maybe we can take it back now to this issue of increasing awareness. And I mean, these issues you're talking about in terms of the financing and incentivization models do link to policy decisions that need to be taken, not just by industry, but by governments in particular. But I think, as Liang, you were mentioning in your presentation, the AMR narrative has really been taken over by COVID-19, but even pre-pandemic, I think there were issues of whether awareness and even having a national action plan translates into key follow-through. But on a broader level, there are some questions that came through from the registrants at the beginning, and perhaps I can pose these to Liang and Fabio and Yuanyo. How is the issue across different countries? And I think you did mention this to some degree, Liang, when you look at the issue of awareness of AMR. But the question really is a comparative one. Who do you think is doing better? And what are the key success factors in the understanding and awareness of AMR issues? So Liang, would you like to maybe have a stab at this first?
Thanks very much. And that's a tricky question because trying to compare between different countries is in many senses like comparing between apples and pears. There are countries that are very serious about antimicrobial resistance. I've mentioned in this region, Thailand, Vietnam as well has put in a lot of work. And then for the rest, there are other priorities. Singapore, we are fortunate in that we are small and well-resourced enough that we can do many things at the same time. And so antimicrobial resistance is something that's been minds of our agencies and the Ministry of Health as well.
Thank you. That's a very diplomatic response. Fabio, could I ask for your assessment? You wrote the white paper.
Okay. So look, I think one of the things that Liang said is correct. Is it's a matter of priority, right? For example, for a long time, China actually did not have priority on antimicrobial resistance. The priority was to care for a very large population and with scarce resources within the healthcare system. I think Thailand and Vietnam are actually doing a fair amount on this. The rest of the countries is a very low priority for them. Again, and I think it's understandable in the sense that it is that they do have a number of priorities, contending priorities that they're working with. But again, it does create a cost to the healthcare system that is completely avoidable. And so there should be an incentive to think about doing better than they currently do. One other thing that actually is on the horizon is technology to help with antimicrobial resistance. Because we've seen AI application, for example, in the US, where by analyzing electronic medical records, you are able to pick up patterns in infections within hospitals that allow you to identify potential issues with antimicrobial resistance a lot earlier on than you would otherwise. If you're the head of infectious diseases within an hospital and are also in charge of controlling, an epidemic within the hospital. So that manual process takes a long time. with a AI predictive tool actually takes a lot less. So I think there is also advancements in, again, in the surveillance space and in the hospital space that will allow people to do better, but that's only up to a certain point. I think that the issue that I was trying to bring before is, as a single country, you have a limited amount of responses to this. What you cannot affect is new antibiotics and new diagnostics. So that will always be a limitation from a country perspective. But yeah, that's the, you know, if I were to pick a few countries that are not doing terribly well, is I would say everyone excluding Singapore and excluding Thailand and Vietnam.
Okay, thank you. That's a very clear response. I think this does relate to one of the questions in the Q&A, asking what are the APAC health authorities doing to tackle AMR in the region. So I think you have given a broad overview of that. But would any of the other panelists like to sort of address that as well from your assessment of the region? Maybe Barry, from an industry perspective?
Yeah, I think the first thing, Professor Lim, is that we want to look at how we can remove regulatory hurdles to, or regulatory expense to bringing a product into a country which may not get very much use at all, but is still a very important tool to have in the armoury. And so if we could find ways to have some sort of regulatory harmonisation so that we prepare one submission for a country like Singapore, for example, and that same submission can be used in other neighbouring countries, or a registration in one of the markets automatically gives registration in another market, for example. You know, if you look at the Australian market where I'm based, you know, it's many hundreds of thousands of dollars just to register a product before you go into the research and development. So if we could find ways to reduce that barrier, that would be a very helpful start.
Of course, that always brings up, I think it's not just a question of antibiotics, right? When we talk of issues of regulatory harmonization, it really cuts across the board. But I suppose, again, as Liang was saying in his presentation, because we've seen a lot of this agility convergence happening in context of COVID-19, these are kind of lessons that really ought to be codified and extrapolated to other products, including antibiotics, to deal with these kind of issues. There are some specific questions in the Q&A, but let me try and clear these from the registrants first. And there's another question that says, should there be a revamp in the indications and prescribing practices for antibiotics, perhaps even managed access? How would you, what are your thoughts on this, Yano, in terms of dealing with prescribing practices and access to antibiotics in an inappropriate way?
I think, yes, thanks. There was a mention about literacy, public literacy as well. I think that's part of it. I feel that Singapore, I think the health literacy of our general public is still quite low, and it's something we seek to improve. I think with viral infections, I think one of the areas is to equip them with that knowledge, the public, the knowledge that viral infections do not need antibiotics. That's part of the campaign in the past 2 years that we've been rolling, HPV has been rolling out. And also to equip them with the knowledge that viral infections take time to recover, so that they, what can they do with, in the meantime to help themselves, whether with OTC, medications. We're not encouraging self-diagnosis here, but taking time to wait it out, so to speak, rather than to hop from a doctor to another doctor. And then on the prescribing side for the GPs, then we try to improve the prescribing practices through either continuing education or development of guidelines for common conditions. But perhaps Liang, you have something to add as a clinician point of view.
Yes. In fact, I would say something here, if I may. And I think the issue for many countries, unlike Singapore, is a balance between access to antibiotics and access in terms of how antibiotics are used. And I once went to this village in Bangladesh. It was like a 2.5-hour drive, and our four-wheeler got stuck in the mud. And we had to come out to push the car for several minutes. And we went to this village, and in the pharmacy, they were selling very brand new updated antibiotics that you would find it hard to get in a GP in Singapore. I thought, wow, that's really amazing, right? Because on the one hand, we can see that antibiotics are life-saving. There will be no doctor within miles of this village to prescribe the antibiotics. So if you try to have only prescription antibiotics, then you can see that a lot of people are going to fall through the cracks. I don't have a good solution for this, but I do think that one of these is perhaps to think about educating not just doctors, but to think more broadly about who can prescribe antibiotics and to try to provide clear guidelines for them to do so. Over.
I think one of the big challenges that we see in all societies or in all environments is that as a healthcare provider, my obligation is to the patient in front of me first, and then to the broader community second. And there's incentives if you're a private surgeon working in a country with very high levels of resistance. I'm going to use the most powerful antibiotics as prophylaxis for my patient, because I don't want my patient getting a post-operative infection. Now, that's not appropriate prescribing, but you can understand some of the motivation behind that. And Liang, I don't know if there's a way of addressing that.
I'm not sure either, Barry. I suspect it's got to do with people thinking and acting in an evidence-based way, and that's where those guidelines might be useful.
But anyway, I think this whole need of literacy education is a critical thing that needs to be stepped up as well across the board. It's in many areas. Liang, while you're on, can you talk a bit about strengthening surveillance? And there was a question about how can we, well, the question is, how can we install the GLASS program, the Global Antimicrobial Resistance and Use Surveillance System of WHO in countries? And what are the critical points to take note of?
So I think it differs for many countries. Even in Singapore, I understand we had some issues submitting data to GLASS because of the formats or the data types that they require. So it does take a lot of resources to get enough data from enough hospitals, healthcare systems in the region. And either a country's leadership has to make that a priority, or WHO or other agencies have to provide the know-how. And a lot of this is done piecemeal. For example, there is a Fleming Fund from the UK that helped to fund the development of labs in countries. But these things lapse, right? Once the UK economy goes down, then all this aid gets cut as well. So I think there has to be a balance here. And perhaps in regional groupings like ASEAN, maybe Singapore or Thailand will be in a place to help other countries to achieve this.
Hi, could I jump in here? Yes,
please.
Because
yes.
I'm the focal point for GLASS in Singapore, so I could perhaps offer some advice here. We had initially did have problems, but now we have contributed data, and Singapore's data is on the GLASS report and GLASS website starting from last year. So I think because if you're asking for critical points, I think this may take up the whole webinar, but I think in a nutshell is to start small and build up from there. And you don't have to have all the data that WHO GLASS needs. That's 8 pathogens across 4 different types of samples, but you could start with one. You could start with one sentinel site, and that's break it down into very digestible bits, and then build up from there. But whoever asked that, if you need us to share our experiences, I'll be happy to discuss this offline and share our experiences with you.
Thanks, Yanil. Let's move to the questions in the Q&A, because I think we do need to try and answer them. Some of them are quite technical, but let's go in some order. So the first one was, are blood cultures the mainstay model or mode, I suppose, for determining infection and testing resistance? Who would like to respond to this question?
Yeah, maybe I should.
Yes, please.
This one. Yeah. So blood cultures are often done for very sick patients because to diagnose sepsis, you would like to isolate the organism out from the. In many poorer countries and hospitals, because their resources are limited, then this is the main form of cultures that they do. But of course, in Singapore, we do a lot more than that. And we also understand that just like COVID-19 has asymptomatic infected persons, for AMR, there are asymptomatic infected persons who serve as reservoir to transmit the bacteria to other people. And ideally, you want to be able to test for these two, not in the blood, but in the stool or in their noses, where these bacteria reside. Over.
Thank you. There are two questions dealing with diagnostic tools. So the first one is about the escape pathogens mentioned by Fabio. Would diagnostic tools be able to detect these pathogens in a short period, say within 3 to 5 hours, to help with AMR in public tertiary hospitals? And then the questioner says he understands that empiric therapy is usually given. Would diagnostic tools be helpful in order to zoom into targeted therapies? And of course, there's a related question. Are hospitals doing sufficient testing with diagnostic tools to avoid AMR? Yone, would you like to have a bash at this first, and then we can ask the other panelists?
Could I hand this over to Liang as a doctor?
I'm so sorry.
Just to spread this out in some way, but Liang, if you're the right person, please carry on. Yeah.
It's quite a technical question, but in some ways
it is.
It relates to funding as well, right? The issue with diagnostic tests is that they add on cost to the payers. So for GPs, where it's out-of-pocket payments, for instance, most GPs don't like to test patients for urinary tract infections or other things simply because, number one, by the time the test comes back, the patient is gone. Number two, the antibiotic is going to cost $10 and the test is going to cost $50, right? So nobody is willing to pay the price for this thing. So that's a dilemma that has to be tackled. But it is true that there are more rapid diagnostics being developed for antimicrobial resistance, and they are also deployed in many of the tertiary hospitals around Asia, in Singapore. Those panel tests that gene experts do for TB and TB resistance, for instance, there's also a panel for the most resistant bacteria at about $160 per test, right? So it does come at a cost, which is the limiting factor of it, just like new antibiotics in that sense.
I mean, maybe if I can add,
Please,
I
Fabio.
don't have a medical degree, but I've done work on diagnostics in Asia Pacific, and one of the things that we have noticed is exactly what Liang was saying, is the fact that the cost actually inhibits and prohibits medical practitioners to test. And so what happens is, a lot of times smaller hospitals will use blood cultures, take 24 hours, not do the 2 bottles at the same time, but do 1 bottle before the other, just to save cost. And then what happens is you see that the infection actually spreads. And that's the difference between having rapid ID on the bacteria and rapid diagnostics on the antimicrobial resistance versus not having that. And again, the cost is the main barrier, unfortunately. And so that's what we've seen in practice across, again, Asia Pacific. Singapore situation is, again, slightly different. But if you go to a rural hospital in Thailand, unfortunately, not one of the 34 area hospitals, that becomes an issue.
There's one more set of questions still linked to testing. 3 questions, actually. Is point of care testing currently being done in hospitals? What would be an ideal approach to such testing as part of an AMR stewardship program? Secondly, what are your thoughts on implementing molecular approaches to point of care testing? And thirdly, what are we working towards or hoping to achieve in terms of diagnostic stewardship? So I wonder, Liang, I think you'll have to respond first.
Yeah, that's all very technical. So hospitals don't do very much point of care testing in the sense that we understand point of care testing, right? They'll still take the sample and you'll still go to the lab. And that's in a very complicated way for governance issues and for getting the test results into the hospital system. But as we're seeing with GP clinics deploying point of care tests for COVID-19, the antigen rapid test, we can ideally see this as a point of takeoff for AMR testing in the clinic as well. And then I think you had another question about, trying to look through the questions now, sorry.
Molecular approaches.
Just if I can add,
yes.
when you look at the white paper that LEK produced, Fabio's team produced, then affordable point of care diagnostics is a key pillar of going forwards in combating AMR. And it's an area where, if you look at the funding that's required, is going to need significant funding, perhaps at a government level, to help make that available, because from a company perspective, it's a bit of a holy grail to crack, I would imagine. And so, yeah, a big focus would be required.
That's right.
Yeah.
And to address the last question on diagnostic stewardship, I think that is like a growing movement that is spreading across the world, just like antibiotic stewardship is. So quite a number of antibiotic stewardship teams also apply this concept of diagnostic stewardship now, which is to try to tell doctors to use the right tests for the patients and not to think too much about saving costs upfront, because it would cost the patients more further down the line if the diagnosis is not made and the appropriate treatment not started.
Thanks. There's a broader question which follows next, which is really the link between excessive use of antibiotics in animals and antibiotic resistance in humans. And I think the question is there, well, to explain this link, but also, is there any regulation restricting these areas? Who do you think can answer this one?
I guess I'll take that one. Okay.
Please.
Yes, thanks. That is a question that we face very often. I think there are two links here. First is the link between antibiotic use and antibiotic resistance. And I think that is also well established, not just in animals, but humans. Antibiotic use leads to increased resistance in flora. Then the other link is the link between animals and then animal products and then resistance in humans, which is a bit more tenuous. The evidence is not as strong, but I think increasing evidence is coming up. There have been studies, I think Denmark, Netherlands have done some studies linking these. There are two ways the resistant bacteria gets passed on to humans: consumption, and I think with of products that have that carry resistant bacteria or bacteria anyway. They'll carry bacteria, not taking sterile food. So it's in the product. It could be you get foodborne diseases, and foodborne diseases, if it's like salmonella, some of them do carry resistant genes, and that makes a resistant foodborne infection more difficult to treat. And then there is the normal flora in the gut of the animal, the E. coli and so on, and they too carry resistance. And those are resistance determinants. They don't cause food poisoning, but those resistance determinants can be passed on. And so that's looking at more of these kind of transmissions. And of course, then besides consumption, there is also the handling part, the handling of raw, uncooked meat, for example, and then related to poor hygiene practices. And these are that's the link that we are concerned with, and that's why we're paying attention to our food and the food chain. As for regulations, in Singapore, yes, there are regulations on antibiotic use. Our farms in Singapore are all licensed, and there are directives given to these farms that they cannot use antibiotics for growth promotion. There are certain antibiotics that are banned, for example, carbapenems, because they are medical importance. And other antibiotics and compounds that are also banned because they pose a food safety risk. Then we do have a very robust antibiotic residues monitoring program, and there are regulatory actions when products are found that exceed the residual limits.
Thanks, Yanil. Liang and Fabio, can you talk about the region more broadly, especially when we think of the regulation addressing these kind of issues?
Fabio, would you like to go first?
Yeah, I mean, I think that the greater regulation I've seen is actually in Europe. In Asia Pacific, there isn't too much yet. There is only certain countries that have some regulation, Singapore being one. But I think that that's an area that definitely can be worked on.
I also see it as progressively getting better. There are very strong farmers' unions or groups in Asia, in Thailand, in Vietnam. It's not just strong in the United States or Europe, for instance. And they exert a lot of pressure on the ministries to not to change the way things are being done and not to add costs to them. So in Thailand, for instance, you can buy like a tin of antibiotics for a few dollars, and this then goes to the animals, right? And in Vietnam, you can buy chicken feed with 13 antibiotics with them, and it's advertised broadly. But these things are slowly changing because I think governments are now understanding that they have to offer an alternative if they want to stop the farmers from using antibiotics, and to teach them how to grow their animals in a safer way.
Yeah, it's a very good point. And I think it comes back to the issue we were talking about before, which is you have an individual farmer who his livelihood is dependent on him growing a good herd of animals. And how do you give him incentive to change his practice when the antibiotics improve his profitability? It's a very challenging area to address.
Yep. But again, as Liang said, I think there is movement. So we need to encourage this. And I think through these kind of webinars, as we convene discussions amongst policymakers, I think we can begin to move the needle, but it's really to keep this awareness there. There is another question now about really public responsibility. What can we as members of the public do in this regard to sort of address AMR issues? And it goes back, I think, to an earlier point on family physician prescribing. Do we second guess or question a physician or dentist when we're prescribed antibiotics? That's a rather open-ended question. Yenio, what do you think? Again, it goes back to public literacy, education, and that's a big topic.
Yes, I'll answer the second part first. That it's easier. No, don't second guess your doctor and dentist. We encourage the public to take the advice of their doctors and then work to improve appropriate prescribing practices. So please follow the advice of your doctors and dentists. The first part of the question was, let me see, what was that? What can members of the public do in this regard? Yes, recognize that antibiotics are not effective against the common cold and flu and all viral infections, and then practice safe hygiene. I think that's come very strong in COVID, that there's a lot of emphasis on infection control and hygiene, washing your hands, and all this help prevent infections. And then there are safe food practices, that cook your food well, and in keeping raw and cooked food separate. These are the things that we can do to limit the spread of infections, as well as reduce unnecessary antibiotic use.
Thanks. I think that answers actually another question that was there on reducing the non-medical uses of antibiotics. There is a very, very specific question on the use of new nanomaterials for combating antimicrobial resistance. Are any of you able to address this particular one on the further development and applications bench to bed of new nanomaterials-based antimicrobial agents to combat antimicrobial resistance?
Yeah, maybe I can try my hand at this question because I've been involved in some of these projects. I think the issue for the longest time has always been acceptability of this kind of nanoparticles that's injected into the body, and the issues of how do you assess safety, right? But now that there's this huge discussion about the nanolipid particles that surround the mRNA Pfizer vaccines, perhaps it'll become more acceptable. But certainly, I think these products still need to be tested in the usual way and be monitored for safety concerns. But they have been deployed in multiple situations, including for cancer and other things, and they seem to work very well. Right? So it's a matter of testing and rolling them out.
Thank you. Let's take the issues a bit more broadly first. There is one question actually from my colleague on the recent experience of the challenges that COVAX has faced in raising funds and in equity in distribution, even in a global pandemic. How can we ensure that AMR global funds and bonds don't end up the same way with rich countries at the front of the queue? Fabio and Barry, would you like to respond to this one? Fabio first.
I can try. I mean, I think, you know, the way COVAX has worked has actually been somewhat disappointing. It hasn't achieved the objective that is set out to do in the first place, which was to distribute vaccines where vaccine access was always going to be a problem, both from a cost perspective, but also from a procurement perspective. And we all know that vaccines have supply issues, which have manifested themselves in COVID as well. So, look, I'm not sure how we can ensure that this won't work. It takes goodwill at some point from the various entities and nations involved. And I think that there has been a lot of, you know, nationalism and politics within the distribution of the COVAX vaccines and within the, you know, within the way that has been essentially administered. We knew of doses in various rich countries that were about to expire that were never sent to COVAX, for example. So again, it does take a little bit more goodwill than we've seen. And I think one of the things that will help AMR is that it's not as politicized of an issue as COVID has been.
Yeah, thanks, Fabio. And if I can just come on top then, what we've been doing, John, in our own work is we've been classifying the countries in Asia based on their level of antimicrobial resistance and the need for intervention. So if you look at a country like Singapore, the actual level of AMR is much less than if we go to some of the developing countries. And so when you look at things like the AMR bond or any of these other financial solutions, then I think we automatically need to screen the countries and look at putting them into only making them available in the countries where the need is the highest. So it wouldn't make sense to give Singapore money for an AMR bond, but you know, perhaps in a country like Laos, it would make a lot of sense. So yeah, we need to be sensible about where we make those sort of things available.
Liang, anything to add to this?
No.
Thank you. But it's an evolving area, and I think as we've experienced in COVID, well thought through policy options do run into significant issues at a national and regional level. And I think these kind of policy issues have to be dealt with collectively. But certainly, as we've seen in the COVID situation, when I think countries respond very specifically with very narrow interests, it does become a concern. So I think it's a broader issue that we have to address at a health systems level regionally. There is a question also in relation to surveillance. Do you advise that antimicrobial resistance demonstrated by failure of treatment be reported as part of pharmacovigilance programs? These are adverse event reaction programs, usually linked to health product regulation. What are your thoughts on this?
That's a very interesting point. And I think there have been suggestions to do this. I remember that there was a publication about using pharmacovigilance databases as a way of picking up drug resistance or treatment failures, right? But I'm not sure that it has gone any further. And I'm not actually sure if it adds anything to if your surveillance system in place that looks at drug use and antibiotic resistance rates and ties that to outcomes. Yeah, but if you don't have those, then I suppose the pharmacovigilance data will help.
Fabio, do you have any thoughts on this one?
Sorry, I was trying to unmute myself. So I do think that there is also an issue around, admitting that there has been a mishap in the hospital and potentially by a doctor that will sort of prevent from reporting these kind of issues. I do think that it would be helpful to have some form of repository to start tracking exactly where infections are happening, how many patients are involved, what kind of resistance we're seeing, simply because it's essentially surveillance. I would think that I would rather reinforce the surveillance system than trying to report this as a pharmacovigilance issue. Yes, so I just saw that then the question, which I think is essentially affected in Asia countries, this can be low quality or fake. Yes, that is very true, unfortunately, but it's again a completely different issue. How to tackle that is extremely complex. And we have discussed it with a number of different pharma companies, but there isn't a good solution for that, unfortunately.
Right. Thank you. One question, is it possible to repurpose existing drugs to tackle AMR?
Maybe I can answer that. I think that
Fabio, yes.
The short answer is no. The issue with antimicrobial resistance is that the fact that these drugs are the drugs that are causing the resistance in the first place. Most antibiotics will have that effect. So essentially, you'll be trying to use the very drugs that bacteria have grown resistant to. I would think is sort of the short answer to that.
The long answer might be yes, in the context that if we can stop the inappropriate use or reduce the use, then some of the antibiotics that are now currently not so effective may have a second life if we can actually change the usage patterns.
Yeah,
right.
I agree with that. I think the straight repurposing wouldn't work.
There's actually a follow-up to the previous question on pharmacovigilance. So the questioner, whom of course we know very well, he's highlighting the point that antimicrobials can be low quality or fake. But Liang, you had some views on this previously when we were having our pre-webinar discussion, that your sense was this is not as significant an issue as, for example, anti-malarials. Could you comment further on this?
Yes, that's right. And some of my colleagues who have been working in the region, specifically to detect fake or low quality drugs, have found that antibiotics tend to be very low on the list of the drugs that they survey. I think largely because they are so cheap, right? That it doesn't make too much sense to try to make too many of these fake antibiotics. So the problem is small in relation to others like anti-malarials, for instance.
And there's just a related comment, in fact, saying we do need to monitor and record the failure of antibiotic treatment and antimicrobial resistance in pharmacovigilance, especially in life-threatening conditions. So we take note of that comment. There's a question on pharmacometric approach employed in Singapore to tackle AMR. Yanio, are you able to respond to this one?
Sorry, I'm afraid not. I'm actually not clear. I don't understand the term pharmacometrics. Sorry.
Liang, are you able to shed light on this?
I think the term refers to using models to try to apply to drugs, I guess to see whether you can determine a better way to prescribe them in that sense and to look at their beneficial effects and adverse effects. I think it's already being done in a certain sense. In SGH, for example, that there are pharmacy teams that do research in this area. But other than that, I don't know much else that's been done for this field. Over.
Okay, we'll take note of that because time is running out. There is one final question I've left to the end, which is extremely technical. And I don't know, Liang, would you be able to help us with this on novel technologies to complement blood cultures being able to detect escape pathogens directly from blood, such as T2 biosystem bacteria and candida panels in terms of AMR? And then the comment is that cost is usually a factor, but what other factors do you think may help clinicians be convinced to use such technologies when you're thinking of novel technologies for AMR prevention?
I think the person asking the question has sort of answered his own question as well. So there are such things out there, and there are many companies and startups, for instance, in US and Europe developing these things, including one that uses deep sequencing to try and pick up bacteria and viruses from the blood, and also trying to pick up the resistance genes at the same time. And there are others that develop panels, like film array is being used in Singapore as well as multiplex PCR options. So there are all these things out there gaining traction, trying to deal with the additional cost hurdle at this point in time. And I tend to think that for now, they're mainly applicable to large tertiary hospitals, mostly in high-income countries because of the cost barrier in low-income countries and community hospitals.
Well, thank you very much. So time is running out and my internet connection seems to be getting increasingly unstable. So that's probably an indication we need to draw this webinar to a close soon. But in closing, could I just invite each of you maybe to give one or two key takeaways that you would like to leave with the audience? And perhaps I can start with Yenyo and then move to Fabio, Barry, and ask Liang to have the last word. Yenyo?
Sure, thank you. Thank you for this opportunity. Two things probably that comes to mind with regards to these pooled incentives. I think for access, we need to push incentives. We need to look at stewardship, but then there is a gap in the pool incentives. And I think this is a good time to start these conversations, especially in the light of COVID, where policymakers are rethinking the way drugs are accessed, the value of drugs are assessed. So it's a good time to start these conversations, and I hope that will continue. Secondly, from the One Health perspective, then, is not to neglect similar needs in the food production sector, particularly not so much for antibiotics, I suppose, but I think in the area of diagnostics and vaccines for the region in the food production sector, that is also there is a great gap there too as well. Okay, that's all from me. Thank you.
Thank you very much. Fabio?
Sure. I think actually only one key takeaway, which is while there has been a fair amount done by certain countries on antimicrobial resistances, there needs to be a coordination that is above that. And I hope that the ASEAN forum, some of the WHO forums, but also potentially something that is more Asia-Pacific based, could start that conversation and see where the issues around diagnostics and R&D and commercialization can be plugged.
Thank you. Barry?
Yeah, mine's a fairly simple message, and that's just around the need to start early. Clearly the need is there. There are many solutions that have been proposed. It doesn't matter which solution we want to go down. We need to start now, and we need to start building the ecosystem and the infrastructure to support that. Because what we don't want to have happen is that COVAX-like situation where things get locked up and tied in knots. So yeah, just starting early would be my key request.
Thank you. And Liang, the last word.
Thank you. And I think the rest have already said basically everything. But I'd like to say what a wonderful webinar this has been. And if you asked me a year ago whether Duke-NUS Core would organize AMR webinars, I would have gone like, huh? What's but the fact that you're doing it is great. The fact that we're on this panel with industry, with experts from overseas to AMR Zero, I think that's fantastic as well. And I think it would be great if we had more of these in the future, not just in Singapore, to get people of diverse backgrounds and interests to come together. Then we will be able to come up with better solutions for AMR in the future.
Well, thank you very much, Liang. So let me thank the panelists, each of you, for your time, and especially for your very insightful and specific responses to the questions. And perhaps the final point is one we said at the very beginning, that the COVID-19 experience has taught us many things, and we can use those learnings to actually enhance our response to antimicrobial resistance. So with that, thank you very much for your time this afternoon. It's been a pleasure interacting with the panel, and thank you to the audience for being with us. And we look forward to further engagements, not only on antimicrobial resistance, but other key topics to address health and health product concerns. So with that, I will draw the webinar to a close, and thank you very much. Stay safe, and we look forward to seeing you again soon.